Welcome to the Hospital Medicine Unplugged podcast. Today we're diving deep into a really critical issue: hepatorenal syndrome, acute kidney injury, HRS-AKI, specifically in our hospitalized patients with cirrhosis. Our mission here is to take the latest guidance, from the AGA and AASLD and synthesize it, make it practical for diagnosing and managing this acutely on the wards. Because let's face it, HRS signals a profound deterioration. The margin for error is just razor thin.
It really is. It's that moment where cirrhosis tips over into, true multi-organ failure. HRS isn't just common. It's basically a declaration of end-stage physiology. Seeing it has to trigger an immediate high-alert response from the team. We absolutely know that any delay, any hesitation, it just drastically cuts down the already slim chance of survival. This makes it one of the most time-sensitive diagnoses we deal with in hospital medicine. So our goal today is to make sure you know the exact steps, and maybe just as importantly, the pitfalls, to navigate that critical window.
Okay, let's get right to it then, the definition. Historically, we waited for these high fixed creatinine thresholds before sounding the alarm. That whole approach is, it's obsolete now. So what is the current consensus definition of AKI and cirrhosis? And why is this change such a clinical game changer for picking it up early?
Yeah, the shift is fundamental. We moved away from that fixed number precisely because it was missing people, especially those with low muscle mass. It was biased. So the current AKI definition in cirrhosis centers on the change in kidney function. Specifically, it's defined either by an increase in serum creatinine of 0.3 milligrams per deciliter or more within 48 hours, or alternatively, a rise to 1.5 times the baseline creatinine level or higher within a 7-day period.
And that 0.3 milligrams per deciliter increase, its significance really can't be overstated, can it?
Yeah.
Especially when you're dealing with a population that's often sarcopenic.
Precisely. That's the key insight. Your typical cirrhotic patient, maybe an older adult, maybe a woman, often has a baseline creatinine well below 1.0. Sometimes it's 0.5, 0.6 milligrams per deciliter. So if we waited for a conventional threshold, say 1.5, my goodness, we might have missed 2, 3, even more days of critical decline. Catching that early 0.3 rise lets us identify the injury much sooner at stage 1. It helps us differentiate, is this pre-renal? Is it ATN starting? Or is it HRS evolving? It gives us a much better shot at actually reversing it.
Right. And just to be crystal clear for everyone listening, let's nail down the core pathology. We define HRS-AKI as a functional renal failure. So how do we contrast that with, say, acute tubular necrosis, ATN, which is structural damage? And how does the acute HRS-AKI differ from the more chronic form, HRS-CKD?
Yeah, the functional nature is absolutely key, mostly because it implies potential reversibility, at least initially. HRS-AKI means the kidney tissue itself isn't the primary problem at the start. It's structurally sound. The failure comes from extreme vasoconstriction, which is driven by external systemic forces, specifically the hemodynamic chaos caused by portal hypertension. That's the rapid, acute form we see emerge quickly. The chronic form, HRS-CKD, that's different. It's a slower, more progressive decline, often happening over months or even years. It likely reflects more established, maybe non-reversible changes in the kidney, but for acute hospital management, our focus has to be on HRS-AKI, what we used to call type 1.
Okay. Let's talk about the clinical burden then, because the sheer scale of this problem and its mortality really justifies this intense focus today.
Yeah.
What does the epidemiology look like right now for AKI in cirrhotic patients?
The numbers are pretty sobering, honestly. AKI is incredibly common in this group. We see it in anywhere from 27% to maybe even 53% of all hospitalized patients who have decompensated cirrhosis. That's a huge range, but either way, it's common. And within that large pool of AKI, HRS-AKI specifically accounts for about 12% to 17% of those cases. If you translate that to national figures, we're likely talking about something like 27,000 hospitalizations for HRS in the US each year. So this isn't some rare condition. It's a major high-volume challenge for healthcare systems.
Wow. And when HRS-AKI is actually confirmed, what kind of short-term prognosis are we truly looking at?
It's grim. There's no other word for it. HRS-AKI is an independent predictor of really poor outcomes. The in-hospital mortality rates, they hover somewhere between 19% and 25%. That's 1 in 4, 1 in 5 patients not making it out of the hospital. And if you track these patients out just 90 days, the mortality rate approaches 50%. Half of them are deceased within 3 months if they don't get definitive treatment, like a transplant. That prognosis is precisely why the diagnosis demands immediate escalation. It requires urgent consideration for transplant evaluation. We just can't afford to treat it like any other generic AKI.
Understood. So to treat it effectively, we really need to grasp the engine driving it. Let's dig into the pathophysiology, that central hemodynamic mechanism, starting with the extreme splanchnic vasodilation from portal hypertension. How can we best visualize that?
Yeah, think of the body circulation like a complex plumbing system. Now, imagine cirrhosis suddenly opens up this huge new territory of very leaky pipes, specifically in the gut. That's the splanchnic circulation. Portal hypertension causes the release of massive amounts of nitric oxide and other vasodilators. These make those splanchnic vessels widen dramatically, so you get this extreme splanchnic and actually systemic arterial vasodilation. Now, even if the patient's total blood volume is normal or even high, the effective arterial blood volume, the amount actually circulating effectively to vital organs like the kidneys, just plummets. This state is what we call arterial underfilling.
So the body essentially thinks it's profoundly hypovolemic, right?
Yeah.
Even if there's tons of fluid elsewhere, maybe causing massive ascites. And the body's attempt to compensate, that's where the kidney injury really starts.
Exactly right. The brain senses this underfilling, this perceived low volume, and it panics. It activates its most powerful survival mechanisms, the neurohumoral systems. We're talking intense activation of the renin-angiotensin-aldosterone system, RAAS, the sympathetic nervous system, and release of vasopressin, or ADH. These systems flood the body with potent vasoconstrictors, their main job. Maintain blood pressure to the brain and heart at all costs.
And in the process of trying to save the brain and heart, they've essentially sacrificed the kidney.
Precisely. They cause intense renal vasoconstriction. The arteries supplying the kidneys clamp down severely. This reduces renal perfusion pressure, and critically, it tanks the glomerular filtration rate, GFR. The result is profound renal hypoperfusion. That's the classic functional failure of HRS. The kidney itself, structurally, might be okay initially, but it's simply being starved of adequate blood flow. And this also explains why, unlike ATN, it can be reversible if we can somehow restore that effective systemic circulation.
But as you alluded to, the story's gotten more complex recently. We used to frame HRS as almost purely hemodynamic, purely functional. But now we understand there's a critical role for systemic inflammation. How does inflammation complicate this picture?
Yeah, this is a really crucial update in our understanding. Inflammation plays a huge role. It's often triggered by bacterial translocation from the leaky gut syndrome, basically, worsened by portal hypertension, or it could be from a frank infection like SBP, spontaneous bacterial peritonitis. This inflammation doesn't just worsen the systemic vasodilation. The inflammatory cytokines, the endotoxins, they directly cause renal microcirculatory dysfunction. We start seeing things like oxidative stress in the kidney, maybe even the formation of tiny clots, microthrombi, and potentially some direct, albeit maybe subtle, tubular injury.
But what you're saying is the renal failure isn't always purely functional anymore. If there's significant inflammation, there can be a structural component creeping in, induced by that inflammatory cascade.
That's exactly the takeaway. If the inflammation is severe, or if it goes on for too long, the damage might not be fully reversible just by fixing the hemodynamics. This helps explain why patients who present with really high inflammatory markers, like a very elevated C-reactive protein, sometimes have a reduced response, or maybe just a transient response, to vasoconstrictor therapy. And often, the underlying liver function, the hepatic reserve, is much lower in these highly inflamed states. They commonly present as what we call acute on chronic liver failure, or ACLF.
Good point. And we should probably briefly touch on two other contributing factors, the heart and, well, the belly itself.
Yes, absolutely relevant. First, cirrhotic cardiomyopathy. Many patients with advanced cirrhosis have some degree of impaired cardiac function. Their heart just can't pump strongly enough to compensate for all that peripheral vasodilation. This, of course, makes the effective arterial underfilling even worse. And second, mechanically, massive, tense ascites can cause intra-abdominal hypertension, just sheer pressure inside the abdomen. This pressure gets transmitted back to the renal veins, causing renal congestion that further hinders effective kidney filtration and urine output. It's like squeezing the kidneys from the outside.
Okay, let's connect this pathophysiology back to the bedside then. When we're reviewing a patient's chart, what specific clinical trigger should immediately raise our suspicion for HRS-AKI?
Well, the vast majority of HRS-AKI cases are precipitated by some kind of acute decompensation. Infections are probably the #1 trigger. SBP is the classic critical one. It demands immediate diagnostic paracentesis and empiric antibiotics. No delays. Gastrointestinal bleeding, especially variceal bleeding, is another major trigger because it directly worsens that volume underfilling. And then, unfortunately, iatrogenic causes are frustratingly common. Things like overly aggressive diuresis leading to volume depletion, or performing a large volume paracentesis without giving albumin replacement in a timely manner. That's a big one. And critically, giving nephrotoxic drugs, that's something we absolutely have control over.
And when you say nephrotoxic drugs, we're thinking the usual suspects, right?
Yeah.
NSAIDs, aminoglycosides, maybe even things like ACE inhibitors or ARBs, which, while helpful in other contexts, can just push a volume-sensitive cirrhotic patient over the edge.
Absolutely. Those are the main culprits. NSAIDs are a huge no-no. Aminoglycosides, contrast dye sometimes. And yes, while RAS inhibitors can be beneficial before decompensation, in the setting of acute illness or volume depletion in a cirrhotic patient, they can precipitate renal failure. Stopping these agents is truly one of the very first and easiest interventions we have to standardize. They should be immediate red flags on any chart review for AKI and cirrhosis.
Okay, so HRS-AKI is fundamentally a diagnosis of exclusion. We have to rule out other causes first. This means a systematic approach is absolutely essential. What does that initial assessment look like beyond just checking the daily creatinine?
Right, exclusion is key. The initial workup needs to be comprehensive, but also really swift. We need an immediate history review focusing on recent events. Was there a large volume paracentesis, recent GI bleed, any vomiting or diarrhea, any new medication started, hospital-acquired infections, labs, of course. Daily serum creatinine is non-negotiable. But we also need a thorough urinalysis and, very importantly, urine microscopy performed by someone experienced.
I'm thinking about that urine analysis. What are the classic findings that would point towards HRS-AKI?
Classically, HRS-AKI reflects that intense renal vasoconstriction, the kidney desperately trying to hold on to every drop of sodium and water. So what we expect to see is very concentrated urine. Typically a bland urine sediment, meaning no significant cells, no casts, minimal or no proteinuria, minimal hematuria. We also anticipate seeing extremely low urine sodium excretion, usually less than 10 millimoles per liter. And a fractional excretion of sodium, the FeNa, typically very low, less than 0.1%.
But here's the practical problem, right? So many of these patients are already on diuretics when they develop AKI. Doesn't that make those urinary markers like urine sodium and FeNa pretty much useless?
That is the major practical hurdle we face on the wards every day. Yes, a prior or current diuretic use completely abolishes the diagnostic utility of FeNa and urine sodium measurements. They just aren't reliable then. And this really reinforces why the diagnosis ultimately has to rely heavily on the overall clinical picture, the exclusion of other causes, and crucially, the patient's response or lack of response to that targeted volume expansion, the albumin challenge. Since the urine chemistry can be unreliable, the focus shifts very quickly to ruling out structural causes and seeing how they respond to albumin.
What about biomarkers? You heard about things like NGAL. Are we getting close to having a specific test that can definitively separate functional HRS-AKI from structural ATN right at the bedside?
Not quite yet, unfortunately. Not for routine clinical practice anyway. Biomarkers like urinary NGA, neutrophil gelatinase-associated lipocalin, or KIM-1, kidney injury molecule 1, are certainly exciting research tools. Generally, they tend to elevate significantly in ATN because of the direct tubular injury, but they often remain relatively low in pure functional HRS-AKI. But while promising, they still lack the large-scale, multi-center validation needed to be officially integrated into our standard AGA or AASLD management algorithms for day-to-day use. The reality is, we simply cannot afford to wait for these results before initiating potentially life-saving therapy based on the clinical picture.
Which brings us squarely back to the albumin challenge. It seems like this is the necessary bridge, the key step to differentiate between suspected pre-renal AKI and potentially confirming HRS-AKI. Can you walk us through the specifics of that protocol and maybe highlight some practical pitfalls we need to watch out for?
Absolutely. The albumin challenge is the linchpin of the early diagnostic process after ruling out obvious structural causes. First step, crucially, all diuretics must be stopped completely, withdrawn. Then we start intravenous albumin. The standard dose is 1 gram per kilogram of actual body weight, but usually capped at a maximum of 100 grams per day. You don't want to go over that. This infusion protocol is typically followed for 24 to 48 hours, 2 full days. Now, the critical pitfall here, the thing you absolutely must watch for, is volume overload. These patients often have underlying cirrhotic cardiomyopathy, maybe diastolic dysfunction. Infusing 100 grams of albumin, which is a massive plasma expander, can very quickly precipitate pulmonary edema or significant fluid shifts. So you have to monitor them incredibly closely. Check JVP, listen to their lungs frequently, maybe use serial point-of-care ultrasound looking for B lines, monitor their respiratory rate and oxygen saturation constantly.
Okay, so let's say we do the albumin challenge carefully. If the creatinine gets better after this aggressive volume expansion, then the diagnosis really points towards prerenal AKI, right? Simple volume depletion. But if the creatinine fails to improve after those 48 hours, despite stopping diuretics and giving all that albumin, then HRS-AKI becomes the strong working diagnosis, justifying the next step, which is starting vasoconstrictors.
Precisely. Failure to see a significant improvement in renal function after that full 48-hour challenge is a key diagnostic criterion. It strongly supports HRS-AKI. It implies that the renal failure is due to severe fixed functional impairment that volume expansion alone just cannot overcome. The vasoconstriction is too intense.
We also absolutely have to rule out structural disease. What imaging is mandatory here? What are we specifically looking for or excluding?
Renal ultrasonography. It's mandatory in essentially all cases of new AKI in a cirrhotic patient. Non-negotiable first step. Primarily, we need to rule out post-renal obstruction, like a stone or tumor causing ureteral blockage, although honestly that's relatively uncommon as the primary cause in this specific population. We also need to assess the kidney parenchyma itself. Look at the size and echogenicity. In classic HRS-AKI, the kidney should look normal size, normal echogenicity reflecting that functional nature of the failure. Finding small, shrunken, or highly echogenic kidneys would suggest underlying chronic kidney disease, maybe severe chronic damage, which definitely complicates the picture and the prognosis. And of course, if GI bleeding was a potential trigger, then upper endoscopy is warranted to find the source and achieve hemostasis. You can't effectively treat the kidney if the initial insult, the bleeding, is still ongoing.
Perfect. Let's try to consolidate the differential diagnosis then, just for the listener, maybe some quick clinical pearls. How do we distinguish HRS-AKI from its main mimics in practice?
Okay, 3 key mimics. 1, prerenal AKI. The key here is response to volume. That's why the albumin challenge is the first diagnostic and therapeutic step. If they get better with volume, it was likely prerenal. 2, acute tubular necrosis, ATN. This is often suggested by findings on urine microscopy, specifically muddy brown granular casts. Also, the FeNa, if usable, is typically higher, usually greater than 1%, sometimes greater than 2%. This indicates the tubules are damaged and can't effectively conserve sodium. You might also see some mild proteinuria. 3, glomerulonephritis. This is usually distinct. It presents with much more significant proteinuria, sometimes even nephrotic range, over 3.5 grams per day, and active urine sediment with hematuria, maybe even red blood cell casts. This obviously requires a more specific serologic workup to diagnose the underlying cause. But really, that systematic approach, starting with stopping nephrotoxins and doing the albumin challenge, is the most practical way to sort through these possibilities quickly at the bedside.
Okay, fantastic. So once HRS-AKI is either confirmed or at least highly suspected after that albumin challenge, we need an immediate clear management protocol. Let's break down the stabilization phase first. What are the absolute non-negotiable initial priorities?
Right, immediate actions. 3 things must happen concurrently. First, stop all potentially offending agents. Discontinue all diuretics immediately. Stop all NSAIDs, ACE inhibitors, ARBs, and importantly, stop non-selective beta blockers as well, as they can worsen hemodynamics in this acute setting. Second, aggressively rule out and treat infection. This always involves a diagnostic paracentesis. Never delay this procedure if ascites is present. Start empiric broad-spectrum antibiotics, usually a third-generation cephalosporin like cefepime or ceftriaxone, depending on local patterns. And critically, give albumin concurrently if you suspect SBP, as this is proven to reduce mortality and the risk of HRS development in SBP. Third, optimize volume status. If the patient hasn't completed the full albumin challenge yet, or if there's still suspicion of hypovolemia despite that, continue or administer the IV albumin, that 1 gram per kilogram dose up to 100 grams per day. Again, always watching very carefully for signs of pulmonary compromise or volume overload.
Okay, stabilization is underway. Now moving to the core treatment, vasoconstrictor therapy. For stage 2 or higher HRS-AKI that hasn't responded to the albumin challenge, this is the required next step. Terlipressin is now the preferred FDA-approved agent in the U.S. What's its mechanism and how do we actually dose it?
Terlipressin acts primarily as a selective V1 receptor agonist. Its main effect is causing potent vasoconstriction in the splanchnic vascular bed. This action effectively shunts blood flow away from that excessively dilated gut circulation and redirects it back towards the systemic circulation and, crucially, the renal arteries. This helps reverse that effective arterial underfilling state. It's always administered alongside ongoing intravenous albumin, typically 20 to 40 grams per day, to maintain adequate plasma volume expansion while the vasoconstriction takes effect. Dosing in the U.S. typically starts at 0.85 or 1 milligram IV every 6 hours. It can also be given as a continuous infusion, which might mitigate some side effects. The dose can potentially be titrated up, maybe to 2 milligrams every 6 hours, based on response and tolerance.
Right, the FDA approval really standardized the approach here in the States, but it also came with some pretty stringent monitoring requirements and a boxed warning. How do we monitor for response, and what defines treatment failure? When do we pull the plug?
Yeah, monitoring is key. We track the response primarily via daily serum creatinine levels. The potential treatment duration is up to 14 days. However, the guidelines really emphasize recognizing failure early. The key checkpoint is day 4. If there's less than a 25% reduction in serum creatinine from baseline by day 4 of therapy, the likelihood of subsequent success drops dramatically. Recognizing this early failure is important. It allows us to potentially stop the medication, avoiding further significant costs, potential side effects, and the resource utilization associated with prolonged ineffective treatment. We can then pivot the strategy, likely towards transplant evaluation or RRT as a bridge.
Okay. Now, for patients where terlipressin might be contraindicated or perhaps unavailable, or maybe for those who are already critically ill with shock in the ICU, norepinephrine is the main validated alternative. How does its efficacy compare, and what are the practical trade-offs?
Norepinephrine is definitely a highly effective alternative. Multiple studies, including meta-analyses, have shown it to be essentially non-inferior to terlipressin in terms of achieving HRS reversal. In fact, for patients who present with overt septic shock or severe systemic hypotension along with HRS, norepinephrine might actually be preferable because it provides broader systemic pressure support. The main trade-off is really logistical and resource-based. Norepinephrine absolutely requires central venous access for safe administration, and it mandates ICU-level monitoring. Terlipressin, while still requiring very close monitoring, can sometimes, in carefully selected cases, be managed on a specialized floor or step-down unit, depending on institutional protocols. There's also some thought that norepinephrine might carry a slightly lower risk of certain complications, particularly respiratory issues, compared to terlipressin, but both require intense vigilance.
And what about that older regimen, the oral combination of midodrine and octreotide? If someone's outside the ICU and maybe terlipressin or norepinephrine are truly not options, is there still any role, however reluctant, for considering this?
Reluctantly is definitely the operative word there. Midodrine, which is an oral alpha agonist, and octreotide, a somatostatin analog that reduces splanchnic blood flow. This combination is substantially less effective than the intravenous vasoconstrictors, terlipressin or norepinephrine. The data just isn't as strong. They really aren't considered first-line therapy for HRS-AKI. They should probably only be considered as a last resort, maybe in specific situations where IV therapy is physically impossible to administer, or perhaps in a very stable patient with maybe HRS-CKD awaiting transplant evaluation outside the hospital. But for acute, severe HRS-AKI, the evidence for reversal with midodrine octreotide is quite poor. The standard of care really demands IV terlipressin or norepinephrine if possible.
We touched on the risks earlier, but let's really emphasize this. We're using potent vasoconstrictors and large volumes of albumin. What are the major non-renal complications we need to be constantly vigilant for? Specifically, the cardiovascular and respiratory risks.
Yeah, this combination therapy creates a pretty precarious hemodynamic situation. We're clamping down peripherally while potentially volume expanding centrally. First, pulmonary edema and straightforward volume overload are constant threats, especially given the prevalence of underlying cirrhotic cardiomyopathy. We need a very low threshold to slow down or temporarily hold the albumin infusion if there's any sign of respiratory distress or fluid overload on exam or post-UMAS. Second, terlipressin, because it causes systemic vasoconstriction, carries a recognized risk of ischemic events. This could be cardiac ischemia, peripheral limb ischemia, or even bowel ischemia. We need to monitor for chest pain, EKG changes, cool extremities, or abdominal pain. And finally, there's a specific known risk of respiratory failure associated with terlipressin, highlighted in the FDA warning. This seems particularly pronounced in patients with more advanced ACLF and those with pre-existing respiratory compromise or high volume requirements. Continuous pulse oximetry monitoring is essential, and we need to be ready for early and aggressive respiratory support, including potential intubation if needed.
Okay, let's pull back now and talk about the bigger picture, the long-term outlook. You've mentioned that even if we successfully reverse the HRS-AKI pharmacologically, the overall prognosis remains pretty dismal. What is the typical transplant-free survival we're looking at for these patients?
Yeah, it's stark. Even with a successful reversal of the HRS episode, meaning the creatinine improves significantly, the median survival for these patients without a liver transplant is still typically less than 3 months. Even the responders, the ones whose kidneys get better, they remain in a very advanced state of hepatic decompensation. They're at extremely high risk for recurrence of AKI, for other infections, for worsening liver failure, and just general clinical instability. So this medical intervention, the vasoconstrictors and albumin, it's truly just a bridge. It buys time, maybe stabilizes them, but it is absolutely not a long-term solution in itself.
And given that stark reality, what remains the only definitive cure for HRS?
Liver transplantation. LT is the only therapy that addresses the underlying root cause, the portal hypertension and liver failure driving the whole process.
Let's touch on a really important special scenario. Patients presenting with acute on chronic liver failure, ACLF. These are often the sickest patients in the hospital. What do we know about how they respond to vasoconstrictor therapy, and how should that influence our decision-making?
That's a critical group. Patients with higher grades of ACLF, particularly grade 3, which involves multiple organ failures, they have markedly worse outcomes overall, and specifically, they have poorer response rates to vasoconstrictor therapy for HRS-AKI. In ACLF grade 3, the ability of terlipressin or norepinephrine to actually reverse the HRS is significantly reduced. And at the same time, the risk of serious adverse events from the therapy, especially that respiratory failure with terlipressin, goes way up. So for these extremely sick patients, medical management is often less about achieving full HRS reversal and more about trying to stabilize them just enough to survive the transplant evaluation process and make it onto the list or bridge them if they're already listed. Very early, very proactive referral for transplant evaluation becomes absolutely non-negotiable in ACLF with HRS.
And where does renal replacement therapy, RRT or dialysis, fit into this picture?
RRT is purely supportive care in this context. It can manage the consequences of kidney failure, the volume overload, the hyperkalemia, the acidosis, but it does absolutely nothing to treat the underlying pathophysiology of HRS itself. Because of this, it's generally reserved almost exclusively as a potential bridge to transplantation, specifically for those pharmacologically refractory patients, the ones who don't respond to vasoconstrictors if they're otherwise considered good candidates for a liver transplant. This is a really critical distinction. RRT does not improve long-term survival in cirrhotic patients with HRS who are not transplant candidates. There's no evidence for that. Therefore, if a patient is deemed too sick or unsuitable for transplants, initiating RRT requires very frank, very careful goals of care discussions with the patient and their family. We have to ensure we're not just prolonging suffering or providing burdensome care without a viable path forward towards meaningful recovery.
That's a very important point. Finally, let's think about prevention. What should listeners be focusing on when managing their cirrhotic patients who don't currently have AKI to try and avoid this crisis altogether?
Prevention is key, though challenging. It really involves multiple strategies. It starts with rigorous infection control and surveillance, specifically using SBP prophylaxis, like norfloxacin or ciprofloxacin, in patients who meet criteria, those with prior SBP, low protein ascites, or active GI bleeding. Second, just relentless vigilance against prescribing or continuing potentially nephrotoxic medications. Continuously audit those med lists. Avoid NSAIDs at all costs. Use caution with other agents. Third is careful, judicious volume management. Avoid overly aggressive diuresis that leads to intravascular depletion. And conversely, when performing large volume paracentesis, always ensure timely and adequate albumin replacement to prevent post-paracentesis circulatory dysfunction, which is a known trigger for HRS. And since recurrence is unfortunately common even after successful treatment, prevention strategies are essentially perpetual for these higher-risk patients. For those who have had HRS-AKI reversed if it recurs, retreatment with vasoconstrictors and albumin is the standard approach, alongside urgent reevaluation for transplant.
You really stress this throughout, that essentially all hospitalized patients who present with cirrhosis and any stage of AK should be considered for urgent transplant evaluation. Given that grim short-term transplant-free survival, there's simply no time to waste in getting that referral process started.
That urgency is perhaps the biggest practice change, the biggest learning curve for many of us over the last decade. We used to sometimes view HRS almost as a terminal, preagnal event. Now we have to view it as a mandatory trigger for immediate escalation and transplant consultation. The medical therapy, the terlipressin, the norepinephrine, the albumin. We're using these powerful tools to buy critical days, maybe weeks. But failing to simultaneously evaluate for LAT right away, that delay itself can unfortunately give a death sentence for potentially eligible patients.
So we've thoroughly covered the essential steps. Recognizing AKI early, using that subtle 0.3 mil GDL creatinine rise, making that critical diagnostic pivot with the albumin challenge, and then applying time-sensitive therapy with terlipressin or norepinephrine, always with albumin. We know these steps can acutely save kidneys.
Yes, absolutely. With prompt diagnosis and correct therapy, we can achieve acute reversal of the renal injury in potentially up to 40–50% of patients. And that in itself represents a major advancement, a significant victory for acute care medicine.
And yet, we're still left confronting that terrifying mortality data. Even among the patients who successfully reverse their HRS-AKI with our best medical therapy, their underlying liver disease remains catastrophic. Their median survival still hovers around that 3-month mark unless they receive a new liver. So this really brings us to the fundamental challenge, maybe the provocative thought to leave our listeners with. Given that we now can medically reverse HRS-AKI in a significant number of patients, how should this ability fundamentally reshape not just our acute management, but the actual criteria and, maybe more importantly, the timing for urgent liver transplant listing? How do we ensure we leverage this window of stability we create, not just as acute stabilization, but as the absolute final push toward the only definitive cure?